Cilta-cel or cilta-cel is a CAR T-cell therapy that targets BCMA or B-cell maturation antigen. It's a bit different compared to the other BCMA-directed CAR T-cell therapies in clinical trials because it has two BCMA-targeting single-domain antibodies that bind to the BCMA. CARTITUDE-1 is a phase 1b/2 study evaluating cilta-cel in relapsed refractory multiple myeloma patients. Previously at ASH in 2020, there were data shared with a median follow-up of 12.4 months, whereas in ASCO this year, we are updating those data with a median follow-up of 18 months. The phase 1b portion of the study looked at the safety and confirmed the dose that was used for the phase 2 portion, where the efficacy of this therapy was evaluated. A total of 97 patients were treated with a median of 6 prior lines of treatment. 87% were triple-class refractory, and almost every patient, 96 of 97, were refractory to the last line of treatment. And the median follow-up of 18 months, the overall response rate is 98%, stringent CR rate of 80.4%. With median time to CR or better being 2.6 months, median duration of response of 22 months for the whole population, and the median duration of response has not been reached for stringent CR patients. Looking at response rates according to the different subgroups, such as number of prior lines of treatment, refractoriness to different drugs, presence or absence of extramedullary plasmacytomas or high-risk cytogenetics, the response rates were comparable between 95 to 100%. MRD negativity rates in evaluable patients was 92%. The 18-month PFS and OS rates were 66% and 81% respectively at the median follow-up mark. And no new safety signals with long-term follow-up were seen, specifically with respect to neurotoxicity side effects. As expected for this advanced relapse refractory myeloma patient population and the CAR T-cell therapy, the most common AEs were hematologic in nature, both in terms of any grade as well as grade 3 or higher, namely neutropenia, anemia, thrombocytopenia, leukopenia, and lymphopenia. Whereas metabolic, GI, and other side effects that were seen in the non-hematologic A category were seen in about a third of patients, but very low single-digit percentage for grade 3 or 4. CRS was seen in almost all patients, 95%, but 99% of the patients had CRS resolve within 14 days of onset. The median time of onset was 7 days. Median duration was 4 days. ICANS was seen in 16 of the patients with grade 3 or higher in 2, and other neurotoxicities were seen in 12 patients with grade 3 or higher in 9. But these numbers are the same as were reported at ASH 2020. Of note, no new incidents of neurotoxicity or additional movement on neurocognitive TEAEs were observed. Of the 5 patients who had the movement in neurocognitive TEAEs, 2 or more risk factors were identified. Patients had either had high tumor burden or grade 2 or higher CRS or ICANS or high CAR T-cell expansion. And by introducing enhanced bridging therapy to reduce tumor burden, early aggressive treatment of CRS and ICANS, and handwriting assessments and extended monitoring, we were able to prevent and reduce these AEs in subsequent CARTITUDE program. So at a longer median follow-up of 18 months, cilta-cel in the CARTITUDE-1 study is showing early, deep, and durable responses in heavily pretreated multiple myeloma patients. There were no new safety signals observed, specifically with regards to the delayed neurotoxicity and movement disorders, and the mitigation strategies have reduced the likelihood of those AEs in the subsequent CARTITUDE program. And based on these data, cilta-cel is now being investigated in the phase 2 CARTITUDE-2 trial with different cohorts, including early relapse and BCM exposed patients. And the phase 3 CARTITUDE-4 study is looking at earlier line setting, comparing cilta-cel to standard triplet regimens in that patient population.